Hi, I'm Joni Watson, and today I want to share about primary and secondary prevention of breast cancer. We'll cover both primary prevention, meaning what we all typically think of in regards to prevention, such as diet, exercise, tobacco cessation, and we'll also discuss secondary prevention, meaning breast cancer screening. Tertiary prevention, which includes treatment and survivorship, is absolutely important to improving the health of patients. And all nurses, no matter their specialties or roles, can impact breast cancer. But for the purposes of this learning activity, we'll focus on primary and secondary breast cancer prevention. Let's take a good look at the overall picture of breast cancer, not only in the United States, but also globally. According to the American Cancer Society, over 1.6 million people are expected to be diagnosed with cancer in this year alone in the United States. Of those cases, a little more than 232,000 will be breast cancer. In addition to the invasive breast cancers, nearly 65,000 additional in situ breast cancers, which are called stage 0 and will progress to invasive cancer if not treated, will be diagnosed in 2013. We often think of breast cancer as a disease impacting only women, but that is not the case, as men also have breast tissue. In 2013, 2,240 men are expected to hear the words, "You have breast cancer." Still, according to the American Cancer Society, excluding cancers of the skin, breast cancer is the most frequently diagnosed cancer in women. It is even more frequently diagnosed than lung cancer. Worldwide, 1.6 million people will receive a diagnosis of breast cancer annually. This worldwide breast cancer annual rate equals the overall annual cancer incidence rate for the entire United States. Plainly, as many people are diagnosed worldwide with breast cancer as are diagnosed with all types of cancers in the U.S. The U.S. and the U.K. bear a larger burden of breast cancer than other countries globally. Many people believe this may be due in part to screening practices and technology. Breast cancer incidence has remained stable over the last 5 years, but there was a nearly 7% reduction in breast cancer incidence between 2002 and 2003 as a result of the Women's Health Initiative study that linked hormone therapy to breast cancer, and numerous women stopping hormone therapy to aid with breast cancer risk reduction. While breast cancer is the #1 diagnosed cancer in women, lung cancer actually kills more women than breast cancer does. Breast cancer is the second highest cancer mortality cause in women. Slightly over 40,000 women will die annually of breast cancer within the United States. 99% of those deaths will be women, and the other 1% men. Breast cancer death rates have declined steadily since 1989, and younger women have benefited more from the drop, which is due to enhanced screening and treatment options. While non-Hispanic white women have a higher incidence of the disease, African American women are more likely to die from breast cancer at any age than all other racial groups. As with most cancers, when caught early, breast cancer has a much higher survival rate. In fact, localized breast cancers, or those that have not spread, have an overall 98.6% 5-year survival rate. Even regional breast cancers, or those that have spread to the closest tissues around the breast, have an overall 84% 5-year survival rate. These rates are outstanding when you view them in light of all combined cancers' 66% 5-year survival rate. Poverty and lack of health insurance remain significant factors, even with all other variables adjusted for breast cancer mortality. There are a little less than 3 million breast cancer survivors alive today within the U.S. alone. More than half of those people were diagnosed 10 years ago or less. To give you some perspective on that number, There are about 3 million registered nurses in the U.S. So imagine if every single registered nurse was a breast cancer survivor. That's a large population of cancer survivors, so it's important for both women and men facing breast cancer to know that they are not alone in their journeys. So let's discuss some of the anatomy and pathophysiology of breast cancer. The breasts are part of the reproductive system. Breast tissue is made up of glands for milk production called lobules, and the ducts that connect the lobules to the nipple. The remainder of the breast is made up of fatty, connective, and lymphatic tissue. There are often no early signs of breast cancer, thus the reason for our screening modalities. An abnormal imaging study, whether it's ultrasound, mammogram, MRI, or tomosynthesis, is often the first early sign of breast cancer. Some symptoms associated with breast cancer, though, include a painless mass or lump, nipple discharge, asymmetry of the breasts, including swelling or dimpling, skin changes such as thickening, redness, scaliness, and peau d'orange, which is when the skin swells, but the sweat glands actually look like lots of dimples, resembling an orange peel. Pain is not usually an early sign of breast cancer. It's typically associated with more advanced breast cancer and benign breast diseases. However, if any male or female notices any changes in his or her breasts, it is important to seek medical attention. Breast awareness is key. Patients need to know their bodies well and report any changes to a provider in case follow-up is needed. Breast cancer staging utilizes 2 different methods, so depending on your practice setting, you may hear it referred to in different ways. The first, most easily identifiable method by many nurses is the TNM, or tumor node metastasis model. The TNM stage gives a better picture of the invasiveness of the breast cancer. The T details the tumor size and how far the tumor has spread within the breast and nearby organs. The N outlines the lymph node involvement, and the M defines the presence or absence of distant metastases to other organs. Stage 0 is breast cancer in situ, either lobular or ductal, meaning the cancer is confined to the lobes, or more commonly, in the ducts. And as the cancer progresses, the stage increases, all the way up to stage 4, which is the most advanced. In addition to the TNM method, a much simpler system, the Surveillance, Epidemiology, and End Results, or SEER Summary Stage System, may be used. Cancer registries and public health systems mostly use this classification. And according to this system, local stage tumors are cancers confined to the breast, while regional stage tumors have spread to surrounding tissue or nearby lymph nodes. Distant stage cancers have metastasized or spread to distant organs. As the biologic properties of breast cancer have become better understood, molecular markers including estrogen and progesterone receptor statuses and human epidermal growth factor receptor 2, or HER2 expression, are increasingly used in addition to stage information for prognosis and treatment. All right, so here's the primary breast cancer prevention piece, what we all typically think of in regards to prevention. Breast cancer has both modifiable and non-modifiable risk factors. Modifiable indicates the risk factors are items people have control over and can change, and the non-modifiable risk factors are issues people cannot change. So let's discuss the non-modifiable risk factors first, because they are also some of the most important risk factors for breast cancer. Gender, being female, and age remain the most important risk factors for breast cancer. A woman's lifetime risk of breast cancer is 1 in 8. That's a startling number, and it's often used. It's important to remember that is lifetime risk, so it assumes that everyone will live at least to age 70. Relative risk for breast cancer increases with age. 95% of new cases and 97% of breast cancer deaths occurred in women 40 years of age and older. 75% of women diagnosed with breast cancer have no risk factor other than their age. Previous personal cancer history, as well as family cancer history, is important to assess breast cancer risk, as 5 to 10% of all breast cancers are a result of genetic susceptibility. The BRCA1 and BRCA2 genetic mutations are responsible for most inherited breast cancers, but there are some other mutations, such as those linked with Cowden syndrome or Li-Fraumeni syndrome as well. The BRCA1 and 2 mutations are also linked to other cancers, such as ovarian. 50 to 85% of those with the BRCA1 or 2 genetic mutation develop breast cancer, and they are common in certain ethnic groups, such as Jews of Eastern descent, also known as Ashkenazi Jews. A good personal and family history assessment is key, which nurses in all fields of practice and settings can participate in. A referral to a genetic counselor is indicated if there are more than 2 relatives with breast or ovarian cancer diagnosed before age 50, or 1 relative with breast and ovarian cancer, or 3 or more first or second degree relatives diagnosed with breast cancer at any age, or 1 relative with bilateral breast cancer before age 50, or 1 male relative with breast cancer, or Ashkenazi Jewish descent and breast or ovarian cancer in the family. A non-modifiable risk factor for breast cancer is therapeutic radiation to the chest, as necessitated by a previous cancer diagnosis, for example, because of the imperative to control or eradicate the previous cancer disease. But it also increases the risk of future breast cancer for certain cancer survivors. In addition, high breast tissue density is a mammographic indicator of the amount of glandular tissue relative to fatty tissue in the breast, and it has been shown to be a strong independent risk factor for the development of breast cancer. Breast density is largely influenced by inherited genetic factors, but decreases with age and is further reduced by pregnancy and menopause. Women with the highest levels of breast density have consistently been found to have a 4 to 6-fold increased risk of breast cancer compared to women with less dense breasts. In addition, mammographic detection of breast cancer is impaired for dense breast tissue. High bone mineral density in postmenopausal women also has been recognized as a risk factor for breast cancer in most studies. Bone density is routinely measured to identify women at increased risk for osteoporosis and may help determine a woman's risk for developing breast cancer. The association between bone density and breast cancer is probably mediated by hormonal factors. And speaking of hormonal factors, these include early menarche, which is defined as menarche before age 12, late menopause after 55 years of age, nulliparity, and late age of first live birth, which is defined as age 30 or older. Some people may question whether parity and age at first live birth is non-modifiable, as some women choose not to have children or choose to wait to have children. But for the purposes of this education activity, I've grouped it with other non-modifiable risk factors. It's still important to remember that some do make these choices, and nurses must be aware. For example, I know both heterosexual and homosexual women who choose not to have children. This leads us to the modifiable risk factors associated with breast cancer. Hormone therapy, such as those used postmenopausally, as well as long-term for contraception, are modifiable risk factors, and women using hormones need to talk with their providers to discuss relative increased breast cancer risk associated with such. According to the American Cancer Society, reproductive hormones are thought to influence breast cancer risk by increasing cell proliferation, thereby increasing the likelihood of DNA damage as well as promotion of cancer growth. There are numerous lifestyle choices that are also associated with increased breast cancer risk. We're learning more and more about these linkages, but there's still a lot that remains unknown about the mechanisms of action associated with obesity, which is a combination of poor diet and physical inactivity, as well as with alcohol and tobacco consumption. Weight gain after the age of 18 is linked to increased breast cancer, and postmenopausal weight gain increases breast cancer risk even more. Some researchers believe this is due in part because fat cells secrete estrogen, which circles back to those hormonal risk factors again. I don't know about you, but I find it harder and harder to maintain my weight as I get older. So this is important to remember when caring for ourselves, as well as teaching patients and family members about breast cancer risk. Obese men and women with breast cancer have a 30% higher risk of death than their normal BMI counterparts. And again, while we may not clearly understand all of the mechanisms involved, tobacco exposure, even secondhand exposure, as well as alcohol consumption are risk factors for breast cancer. Alcohol consumption beyond recommended guidelines, which is 1 drink per day for women and 2 drinks per day for men, incrementally increases a person's relative risk for breast cancer diagnosis. The National Cancer Institute has a lovely risk assessment tool online that anyone can use for free. It takes into account both non-modifiable and modifiable risk factors to help people better understand their relative risk for breast cancer development. Now that we know more about breast cancer risk factors, let's talk about the specific breast cancer prevention and screening strategies and guidelines. There are well-researched, evidence-based strategies for preventing breast cancer. Females can change their modifiable risk factors, many of the items we just discussed. Patients should be encouraged to maintain a healthy weight throughout life, meaning they should balance calorie intake with physical activity and avoid excessive weight gain throughout life. In addition, adults should engage in at least 30 minutes of moderate to vigorous physical activity above usual activities on 5 or more days of the week. 45 to 60 minutes of intentional physical activity is preferable. Children and adolescents should engage in at least 60 minutes per day of moderate to vigorous physical activity at least 5 days per week. Along the same lines, we should all eat a healthy diet with an emphasis on plant sources. Eat 5 or more servings of a variety of fruits and vegetables every day. Choose whole grains rather than processed or refined grains. And also limit consumption of processed and red meats. Again, women should drink no more than 1 drink per day and men 2 per day. All patients who use tobacco should be assessed and encouraged to stop using tobacco at every visit via an evidence-based strategy. Selective estrogen receptor modulators, such as tamoxifen, as well as aromatase inhibitors, such as anastrozole, have been used to treat breast cancer and recurrence. However, we're learning more about them as protective agents against infiltrating breast cancer. For example, tamoxifen has been used to treat breast cancer for over 30 years now, but a 1998 study indicated it is protective for progesterone receptor-positive breast cancer in high-risk women. There are some risks with these prevention strategies, though, such as an increased risk of endometrial cancer. Similarly, prophylactic mastectomy and oophorectomy are evidence-based preventive strategies that can greatly reduce the risk for breast cancer. 90% for prophylactic mastectomy and between 47 to 68% for breast and ovarian cancer. Again, these are irreversible strategies for high-risk women, and it's important that women understand their overall breast cancer risk and discuss these strategies with providers. Because there are rarely early signs or symptoms, screening is key for breast cancer prevention. While monthly self-breast exams are no longer recommended as evidence-based practice, it is important for people to be aware of their breasts, appearance, and feel, in case there is ever a change that needs to be reported to a provider for follow-up. Average at-risk women ages 20 to 39 should have a clinical breast exam, or CBE, from a clinician at least every 3 years. A CBE may actually be a routine part of an annual exam, depending on the provider, and this physical exam assesses for any breast changes from baseline. CBE does have variation in technique and competence based on the provider. Mammography remains the gold standard for breast cancer screening. It uses the BI-RADS, or Breast Imaging Reporting and Data System, which actually standardizes results reporting across mammography, ultrasound, and MRI for breast screening. And BI-RADS indicates the kind of follow-up that is needed as a result of the imaging. BI-RADS is scored from 0 to 6. Traditional mammography can have up to a 15% to 20% of false positive results due to improper positioning, technician error, interpreter error, or breast density. Ultrasound and/or MRI may be used in conjunction with mammography, especially if a person has dense breast tissue. Tomosynthesis is a new 3D imaging modality that has a higher sensitivity for detecting breast cancers. A 2012 study indicated tomosynthesis reduced the rate of callbacks for re-imaging by 40%. As of 2013, there is currently only one FDA-approved system for tomosynthesis, and it is not reimbursable by the majority of health insurances still. Breast cancer screening will likely move toward higher tomosynthesis adoption, but it will take time. There are several organizations with recommended screening guidelines. These guidelines have changed quite a bit over the last few years, so kudos to you for working to stay informed on this topic. These are the recommended screening guidelines for women at average risk for breast cancer. Those with an increased risk of breast cancer should talk with their providers to receive more frequent screening guidelines. The American Cancer Society, as well as the National Cancer Institute, as well as the National Comprehensive Cancer Network, all agree that breast cancer screening can begin at the age of 40. A few years ago, the United States Preventive Services Task Force changed their guidelines, which now say that women ages 40 to 49 should have informed decision-making with their healthcare providers, and women ages 50 to 74 should have breast cancer screening every 2 years. There are numerous physical, emotional, and practical barriers for women to have recommended breast cancer screening. Nurses should be aware of these and anticipate providing additional resources, many of which are available in conjunction with this education activity to help women with secondary breast cancer prevention. One fabulous resource all nurses should be aware of and use is the National Breast and Cervical Cancer Early Detection Program, which offers free and low-cost breast and cervical cancer screenings to eligible women. Specific information about this resource and others are located at the end of this educational activity. Nurses are key to improving health and wellness for all, including breast cancer survivors and their families. Nurses can affect the public's awareness and willingness to use screening measures that can detect breast cancers early, increasing the opportunity for cure and survival. Thank you.